children and adolescents is going to start the session. I request all the DHOs, JDHs and deans to take their seats in the auditorium. I request all of you to please be seated, okay, at the earliest possible. Thank you. Two sessions. The first session will be by Dr. Povari Madam, she is a professor, Institute of Child Health and Madras Medical College, More, followed by Clinical Management of Dengue and Adults by Professor Dr. A. Chandrasekhar, MD, HOD, Government Medical College, Sandy. So after that, we will break for lunch and wind up the session. So I request all of you to please be here at the earliest possible in auditorium. So good afternoon all. I request Professor Dr. Povari Madam, Professor, Institute of Child Health and Madras Medical College, More, to start the session on Clinical Management of Dengue in Children. Welcome, Madam.
Respected deans, my teachers, faculty here, let me place my sincere thanks to the organizing committee, our dean and MC and director ICU for having given me an opportunity to stand before you today for the next 20 minutes. So the task given to me for the next 20 minutes is to sensitize on the management of dengue fever in children, most of which is given by standard guidelines we will be following. It's just a brush through of what exactly we will be doing now. Can I have a slide? The scope of the next 20 minutes will be, I am talking about recognition of dengue, facility-based management of dengue, criteria for discharge, and summarize whatever has been taken up. Next slide. We know in this season of dengue, or from September to December, anybody who comes with fever, they want to know whether it is dengue. The most difficult question for a pediatrician or a physician on day 1 or day 2 to say whether it is dengue is difficult. But I would say consider dengue in all children presenting with fever during this season. Next slide. So basically, the categorization of dengue will be dengue with warning signs, without warning signs, and severe dengue. This is mainly to know how to manage depending upon the severity of the illness. So when they present without warning signs, probably we can be little relaxed, look for them, monitor them. Warning signs, if there are no warning signs, they can be managed as OP. That is a small group where we don't worry much about it. Then comes dengue with warning signs, where we need to take care in the hospital setup and look for them to go on for severe dengue. The last category is severe dengue, where they need to be hospitalized, referred early after sterilization to tertiary centers, where they may need inpatient admission with ICU care. So our job at the medical center is to identify who needs to be referred, who needs to be hospitalized, and who needs to be managed as OP. So those ones without warning signs will be home-based therapy, primary ones. Secondary ones are, the moderate ones are with warning signs, and the severe ones are in the tertiary hospitals. So the dengue primarily we should know when to keep it home, when to keep the inpatient to secondary level centers, and when to refer, how to refer to tertiary center. Next slide. The one disease where we have to touch the patient before getting a diagnosis dengue. Without touching the hand and the feet of the child, we cannot identify a severe dengue. So always do a thorough clinical assessment. Touch the hand and feet because they can be pulseless but they'll still be conscious. Measure the weight because it's weight-based management. See the temperature because as long as the child is febrile, they will not leave. It is worrying for the parents, but we can be little relaxed. But as soon as the fever stops, the parents will feel relaxed and we begin to worry because once they become afebrile, they start leaking. That is where the problem comes in dengue. So once they are afebrile, like in any viral illness, once fever is complete, child should be alright, eating well, activity should be okay. But despite fever coming down, child is not doing well, looking dull, not taking food, not active, that rings a bell for us. That is when we have to identify them, to catch them early, because that is when they go to moderate dengue or dengue warning signs. And the third one is the intake output. Always tell the mothers to look up what is the amount of urine the child is voiding. It's very important to measure the amount of urine. And once you admit them, we will have to titrate the fluids. Again, fluids in dengue, it's a double-edged weapon. Too much is bad, too little is worse. So you must optimize the fluids depending upon how they present it. And always look for warning signs in children who are stable without warning signs. And the labs, we don't need much labs to manage dengue. As long as it is mild and moderate dengue, that is without warning sign and with warning sign, you can just have a complete blood count with hematocrits. That's only parameter which will guide our therapy, so you don't have to change the platelets. Don't worry about the platelet counts going down. Worry about the hematocrit which is rising and falling. That is very useful. Unless the child is very sick, you don't run near the platelet numbers. And point of care ultrasound, I think in all college hospitals they should have because
keep the hands on the chest or the abdomen and blanch them, you can see your fingers. That's the initial rash. The recovery rash is something which is reassuring for us. They say itchy rash, we are very happy that they're going to come. Next slide. So temperature chart is very important because once the child becomes afebrile, the problem for the physician start. And the 248 hours after the child becomes afebrile is where we need to watch whether the child goes into shock or leak. Next slide. So how do the labs help us? Yes, definitely they help us. In the febrile phase, if they have a leukopenia, that is a clue that child is running a viral fever and maybe we are going to deal with dengue. In the afebrile phase, hematocrit is very, very important because that's going to rise to the platelet fault. So these are the lab parameters we will require when they are afebrile. Then it is followed by looking at the clinical examination, the edema, the pulse pressures. Please remember in primary and secondary centers to have blood pressure cuffs appropriate for the age of the children because you are going to manage them depending upon their blood pressures and hematocrit. So please have pediatric cuffs to manage children less than 12 years because you need appropriate cuffs. So their weight and the blood pressure are very important to manage a child with dengue. And then talk you need to recognize, measure the urine output. A measuring cup which is available in plastic which costs around 50 rupees. It's the most important gadget which should be available wherever you manage dengue, mild and moderate dengue because urine output is one parameter which is going to help us in the state of hydration. Again, temperature, afebrile phase is very important. Next slide. Dengue with no warning signs, like they don't have severe pain, they don't have vomiting, they don't have breathlessness, they have not started bleeding. So these children are the ones without warning signs. You can treat them as an outpatient, but give them a slip or a handout which says what are the warning signs. So dengue season, when we are preparing ourselves, we have to prepare the IEC materials for warning signs and make it available in the OPD. Every patient who comes with fever should go out only with the warning signs printed and handed over to them. They must look for those warning signs. Second one is about paracetamol. See, we know paracetamol is quite safe in children with fever. Please remember, paracetamol is not a very safe drug in children with dengue when there is a liver involvement. Even regular doses can be catastrophic. You remember the formulations, 125 milligram, 250 milligram, 500 milligram. because majority of the children come to us with dengue. They recover from dengue, but their liver function worsens with paracetamol poisoning. Unless you think about paracetamol poisoning, it's going to be very, very difficult to identify and treat timely. They may need up to liver transplant. So paracetamol poisoning is very common in dengue season. Mothers are panicked. They run with a temperature 99.5, 99.8. That makes them give paracetamol. So too much of paracetamol or every 4 hours paracetamol, it is very, very catastrophic in children with dengue. So always see to it, all your pediatricians or your physicians handling children give the right dose in the right schedule for right duration. You don't have to give them paracetamol unless the child is little tired or sick or uncomfortable. Just the fever. See, paracetamol is not the treatment for fever. It only makes the child comfortable. So don't overdose them with paracetamol because many number of children come to us with paracetamol poisoning. So remember that when you give hydration. Tell them whatever is available in the house can be taken. Home available fluids. Kanji is very good. Ragi kanji or anything you make, any cereal, porridge, kanji or paruppu kanji, rasam or anything is okay. Fruit juices. But see to it they don't contain too much of sugar because they will lose it and that will not maintain the hydration when you contain too much of glucose. So avoid sugary liquids as a replacement. Other all home available fluids, ORS, rice kanji or all equally good. So up to whatever is available in their house, you can ask them to take. That's very important instruction you need to give them. And tell the mothers, urine output every written paragraph. Roughly we say for 1 hour, child should pass 1 ml per kg. So if it voids after 3 hours, maybe 3 ml per kg over 3 hours. So if the output is going down, please ask them to come back to us. And always watch for the warning signs. Tell them what are the warning signs. Hand over a slip to them which has all the warning signs and educate them to reach the hospital timely. No other drug. Please don't use anything other than paracetamol. Fever will not kill a child. So don't use drugs other than paracetamol for fever. And there is no role for antibiotics. Do not write any antibiotics because you know it's a viral season and day 3, day 4 of fever they are going to go down. Not more than 5 to 7 days. By day 5, day 7 they will start leaking. So there is no role for antibiotics. Just paracetamol, hydration, warning signs, ask them to come back. These are the things you need for mild dengue or dengue without warning signs. Next slide. So when to return? When the child is not feeding, not drinking, or less of urine, any pain abdomen, any bleeds, lethargy, restlessness, mother feels, yeah, papa nalla, something is wrong, please ask her to come back. If she has any one of these, ask her to come back. I'll reassure again, please give them the warning signs printed as an IEC material to all children who come without warning signs. Next slide. So now the second group is moderate dengue where they have warning signs, or dengue without warning signs but risks children like children with underlying comorbid states like nephrotic, a diabetic child or a child for whom fluid management is difficult. Those children will also come into moderate dengue or dengue with warning signs. Those children, please hospitalize them. Do not send them home. They cannot go home because parents will miss them. In 48 hours, they will go into shock. Shock kills dengue. And we don't want any death in dengue, so we should prevent shock. So again, the management is hydration and timed urine output. Very, very important. Please ensure that they are taking orally. IV fluids are only for children who do not take oral. 1.5 times their regular requirement only when they do not take oral. And titrate the fluids according to the urine output. Now in this moderate dengue, you need lab signs like hematocrit. So hematocrit and total count will give a clue. Leukopenic child with a high hematocrit started leaking. That is what you looked in this way. So you need some amount of lab in children with moderate dengue. So again, your lab, how frequently you repeat? In moderate dengue, it's 8 to 12 hours. You don't have to do it more frequently. And look for organ involvement. Any enzyme elevation in a child who is sick, they are early identifiers to give us a clue that the child is going into severe dengue. Once the child goes into moderate dengue, either it could worsen with severe dengue or it should recover. So watch for 48 hours. Whether the child is improving the output, appetite improves, child is doing well, or child is going down, hematocrit is rising, or pleural fluid collections, child is becoming sick, becoming shorty. Please refer them early if you think child is going in for organ involvement. And stabilize all these children before referring. Referring could be catastrophic in children who are not stabilized. Next slide. So these are some of the findings you will have in children who are presenting with moderate dengue. You may have a right pleural effusion. In children, when you take the X-ray in the lying posture, you may not have the fluid levels. It may look little hazy. And if you have ultrasound, anybody who's trained can just keep a probe to identify whether there is pleural fluid in the ultrasound. That's one of the findings. And your IBC. You can measure the IBC to titrate your fluids. And these are simple tests which anybody can do it, at least in Taluk hospitals. Next slide. So if you admit them, give them typical fluid protocols. Always prefer to give oral. Oral fluids will never load them, but when you give parenteral, you have to watch for fluid load. So always chart the fluid secondarily. Don't write 1.5 ml per kg per hour for 6 hours or 7 hours. You have to chart them every second hourly or hourly when they are very sick. If there is a child with dengue, physician should stay bedside till the child goes home. That's the important gadget you need to save the child's life. So fluids, depending upon whether they're present with your hematocrits and your blood pressures, you monitor them for shock. Children who are in shock, sterilize them early and send them. Non-shocky children, probably 1.5 times their fluid requirement, you can start them on oral. If they're not able to take oral, start them on IV. And use only isotonic fluids, by which I mean do not use isolate P. It's not to be used for sick children. Use only DNS with potassium added. So do not use any fluid other than DNS because isolate P will make things worsen. Do not stock isolate P. It is not a fluid for sick children anymore. None of the medical colleges use anything below DNS, dextrose normal saline. So please start using DNS rather than any other fluid. And when they are in shock, you will give only normal saline. Do not rush fluids. You need to titrate fluids. Rumba kuduthalum it will load. Less fluid also will be harmful because it will cause shock. So titrate according to the urine output. 0.5 to 1 ml per kg per hour is your goal for urine output. So all the mothers in hospital patients, they should have a measuring jar to know how much of urine the child is voiding. It is very, very important. Look for organ involvement because these children can worsen, increasing liver enzymes, urea creatinine rising. They are all early clues for you that the child is having organ involvement and going into severe dengue. So you can prepare to shift them early to tertiary care centers. Identify the recovery phase. You have treated them with fluids. Fluids need not be given for more than 48 hours in any sick child. If the fluid requirement is there for IV for more than 48 hours, you are in trouble. So do not give fluids for more than 2 days or 48 hours because leak phase is over by 48 hours. If they need fluids beyond that, they are in trouble. And identify the recovery phase, which means the hematocrits will fall, the narrow pulse pressure will widen, and start widening urine, and you know the child becomes well, and that is where the recovery rash appears. Benign rash, the child may complain of itching, it's benign. The heart rates will go down, bradycardia, it is okay, it's a part of the normal phenomenon in recovery dengue. So identify whether the child is worsening or improving after 48 hours. Persistent fever after 7 days during week indicates a co-infection. 20 to 30% they can have some co-infection. We need to work up. It is there to think about antibiotics. Nowhere in dengue there is a role for antibiotics. Next slide. So be prepared in secondary level centers at Taluk hospitals. Keep the unit well equipped. Have the written protocols. Document temperature and weight for every child every day. Strict IO charting. How much fluid the child takes in, how much the fluid is going out to urine. Have ORS corners. Provide rice kanji because most of the hospitals give food. So you can ask them to prepare rice kanji with salt and give it to them. That's a very important value for these children for hospitalized. There are parents all the time வீட்டுக்கு போய் food எடுத்து வர முடியாது. So we can provide பருப்பு தண்ணி, rice kanji we can prepare in hospital. You don't have to have any extra effort for this. So ensure that these are given in the hospital. And display posters or warning signs so that the hospital area they will go through. And that memory will make them understand these warning signs later. And dengue chart is very, very important. You have to monitor. You don't need gadgets to monitor. Simple physician hands will do. And the medicine, laboratory, facility, and the platelet will do.
என்ன பண்ண ஒரு ஆளை பிடிச்சி ஒரு ஆடிட்டரை பிடிச்சி கிரியேட் பண்ணி செலான் கிரியேட் பண்ணி செலானே கட்டிட்டு நம்ம என்னுடைய இண்டிவிஜுவல் செலான் போட்டு ட்ரிப்ளிகேட் செலான் போட்டு கட்டிட்டு அதில் செக் போட்டு கட்டிட்டேன். வரும்போது எல்லாத்தையும் கிளியர் பண்ணிட்டு வரேன். லேடி ஆஃபீஸ் போகும்போது அங்கன்னா ஏதோ தப்பு நடந்தா கூட என்ன சரி பண்ணிக்கலாம், இங்க முடியாது. ட்ரெஷரி
thermometers, weighing scales, BP apparatus, varying cuff sizes, measuring containers for urine output, monitoring chart where you have the time, the date, time, the heart rate, the pulse rate, the blood pressures, the temperature, hematocrits, platelets, and intake and output. These are the monitoring you do for a child affected with dengue. And complete blood count is something which you need in moderate dengue. Concentrate on the hematocrit and the platelets. Chase on the hematocrits, but do not chase the platelet count. That's not going to help us. Bedside complete blood count. Of course, the total count will help us. If the count keeps rising, you know the child is going in for co-infection. That is one thing which the total count can give a clue, because scrub also will be on the rise with dengue. So when they have leukocytosis with thrombocytopenia, hematocrits will not change so much. That's a clue for dengue. Maybe 20% or 50 to 20% they can have co-infections, and scrub is quite common in the season, so you must watch for that. Adequate crystalloids. Crystalloids is what I said. You have oral and DNS or normal saline. Please don't use any other fluid for children with dengue. To prevent hypoglycemia, use dextrose containing fluids without shock. If they are in shock, you cannot give them dextrose containing fluids. Again, colloids. Children with shock in tertiary centers will need colloids, so you please stock them with enough colloids. Blood products for tertiary care, referral hospitals and medical colleges. The standard treatment guidelines for moderate dengue should be available as posters. So, for dengue, which is mild, it's home treatment, you're not going to manage much except paracetamol and fluids and give the warning signs. For moderate dengue, you need to measure their vital parameters, keep them hospitalized, give them strict IO monitoring, and see to it they recover, or monitor them for early signs of going in for organ involvement. That's for severe dengue. Have a written protocol for standard treatment guidelines, and please give them oral fluids as long as possible. If they're not able to take up oral, probably you can give them some IV fluids. Just because the hematocrit is rising, you don't have to start on IV. The more intravenous fluids you give, the more you're loading them, and that will be giving problems when the child recovers. So give them optimal fluids. Too much less or too much of fluids, both are harmful in dengue. That's why I keep saying, titrate with your urine output. 0.5 to 1 ml per kg should be your goal. You give enough fluids to maintain the urine output, that's fine enough. Next slide. Usually we start with 1.5 times the fluid and then titrate as per the urine output. So fluid is the cornerstone in management. You can use ORS, tender coconut water, rice kanji, dal water, any vegetable soup, fruit juices, anything you can use, whatever is available locally in your families, and avoid unnecessary medications. Nothing except paracetamol. Only drug you need is paracetamol, and that too at the right time, right dose for right duration. And fluids according to the expected weight. And we all know dengue children are either normal or overweight or obese, because of these children only can mount immune response to go into severe dengue. We don't see malnourished children developing severe dengue. So you use the expected weight if the child is an obese child. Don't calculate fluids for the existing weight. Calculate what is the ideal weight, and then based on that you can titrate your fluids. And if required, only you will give fluids. Not all children hospitalized will require IV fluids. And again, whenever you give an IV fluid, please monitor your IV lines. They are likely to leak. They are likely to bleed, because the problem with dengue is thrombocytopenia and coagulopathy. So you have to have a watch on the IV lines as well when you give them fluids. And don't charge fluids beyond second hour. 1 to 2 hours fluid, and physicians should be bedside if you have to treat the patient with dengue. You cannot write 8 hours fluid and run away. After 2 hours, you have to see what is happening to the child to decide your fluid further. So you have to do a bedside duty if a child admitted inpatient as dengue. And no IV fluids after 48 hours. It means you are in trouble. If you give fluids beyond 48 hours, if the child needs fluid beyond 48 hours, it is not simple dengue. It's either severe dengue or dengue with complications. said, touching the hands and feet of the child is very, very important. Child will be cold and clammy, but it will be talking to you fully conscious. So touch the hands and feet, touch the pulses, the capillary refill time and the peripheral pulses. They are the diagnostic clues for a child going in for shock. Altered sensorium is the last finding in shock. Children with dengue will walk to you with shock. You send them for an X-ray, they will collapse in the X-ray room. So please be very careful to touch the hand and feet, feel the pulses, and then shift the child wherever you want to shift. Next slide. This is a dengue chart. Sorry, you may not be able to read, but it gives you the date, the time, heart rate, pulse rate, the blood pressure. Please watch on the narrow pulse pressure, 20, 25, 30, there are narrow pulse pressures for each. So identify narrow pulse pressures, and that is an early clue for you that the child is leaking. Again, during recovery, if the pulse pressure widens, that's a clue that the child is recovering. And then comes your hematocrits, platelets, your urine output, and then your intake. So you titrate all this depending upon the severity. Shock irundhuchuna early pannuvinga. If it is not, 2nd to 4th early, you will monitor the children who are admitted as inpatients. Next slide. Next slide. When do you refer? So mild and moderate dengue will be managed at your own centers. Mild dengue is home management. Ask them to come back if there is a warning sign. Ask them to come back every day and have a look at them. In moderate dengue, you hospitalize, you manage for 48 hours, and at the end of 48 hours, you must see signs of recovery. If not, something is wrong, you have to refer them. How do you refer them? Please stabilize them before referral. And all moderate dengue where you think there are problems, it's a diabetic child, child with a kidney problem, child with a liver disease, child with an underlying problem, please refer them early because the course will be a little abnormal in these children. On day 2, you have shock. So those things you cannot anticipate. So all the comorbid dengues, please refer. Warning signs, if your center is equipped to manage moderate dengue, you can stay. Otherwise, please refer them early. Like for example, you see in a primary health center where you think this child is not going to recover or the child has a warning sign which is worsening, please refer them to the nearest medical college. All kids with severe dengue has to be referred to medical colleges or tertiary care centers because they need intensive monitoring. They may have multi-organ problems. They need higher level of laboratory support and frequent monitoring, which is difficult in primary and secondary centers. And dengue with co-infections. You know the child has an eschar. You know the child has hepatitis. Please refer them early. These are the children who will create problems during severe dengue. They need more meticulous monitoring, more intensive management. Have guidelines for referral. Before referral, ensure that the child is stable. What best you can do in your centers, please give them. You can give them some oral fluids. If possible, you can give them some NG fluids. If necessary, start them on IV fluids, provided you can monitor the IV during transport. Without hydration, please do not shift. They may not reach the referral place at all. In transit, if something happens, you know how the problems can be escalated during dengue season. So always ensure that they are stabilized. Their vital signs are stable and they are able to take some oral before referral. Otherwise, give them some fluids, give them some IV and then stabilize and then send them. So have strict guidelines for referral. Document the issues. Why do you want to refer? Maybe it's an underlying nephrotic syndrome, underlying diabetic child, underlying child with a liver disorder, or you are thinking in terms of co-infection, or you think the child comes from a family where they are staying very far and only the grandmother is there. Cannot take care. Please, for social reasons also, sometimes you need to admit them. Take care that the child comes out of the 48 hours of leak phase. That is where we have to help the child. And document whatever issues the child has before referral. And if you have taken some samples for CBC, please update them because the baseline hematocrit is very, very important. We say 20% rise and fall. So that 20% we may not know. If you do not know, 36.5 is a cutoff in children. Anybody beyond 36.5, we already take them. They've started leaking. Please take them for more fluids. Update on investigations. And what we mean by controlled transport is a child who is stabilized before transport. And please inform the caregivers. They are very worried. The name dengue is very frightening for them. So one season in media we see dengue like that. So the parents, to know that the child has got dengue, it's really very, very catastrophic. We know it is mild and moderate dengue, they will recover. Severe dengue are worrisome. But parents do not know what is mild, moderate, severe. Counsel them with whatever they are. Warning signs illa. Severe dengue will be progress aglan. What you anticipate. And keep them updated on the problems that you are anticipating. That solves a lot of problems. Next slide. Transport, please follow the transport ethics. Whenever you transport to medical colleges, tell them you're transporting a child who's sick enough. Call up the emergency and tell them you're referring a child who's this year's coming with this respiratory support. Please give them some oxygen support if they're transferred with shock. So those things has to be there at the secondary level. Timely and safe transport. If you think the child is in shock, better shift early to a tertiary care center. A shocky child can deteriorate very badly during transit, even if it is 15 to 20 minutes. So never transport a shocky child. If it is in shock, start some bolus, at least a 10 ml per kg of normal saline, and then transport with the fluid. Because if you think, ange poi fluid potukalam appadina, that will be too late. That 15 minutes, the child will go in for refractory shock and MODS. Then no matter whatever we do in the medical colleges can save the child. It goes in for multi-organ dysfunction. So please refer them early with fluids. And have some trained person. I don't mean a doctor should be there. A staff nurse or an ANM who can manage an IV line and fluids. See to it the fluid does not extravasate. That's more than enough. So just have a controlled transport whenever you shift them to a tertiary care facility. Trained person is important because they may have to take it. Suddenly the child may become lethargic. To test the blood sugar, you need a trained person. The driver will be there with the attendant only. So please send somebody who can do the blood glucose during transport. And take care of hypoglycemia. That is one thing which can happen in dengue. And inform the caregivers. Always try to get the feedback from the referral centers. That will be useful to handle children in future. And you will feel really very happy if the child you have referred with severe dengue has recovered and is going to come back to you. If you have not been able to recover the child, then we can know what went wrong and so that we can avoid that in the future. Next slide. Severe dengue is a one with severe plasma leak or who is bleeding. Bleeding the petechial purpura is not considered as a major bleed. Bleeding to that extent to cause hemodynamic compromise, hematemesis, melena, IV size ooze, large hematomas. Those things are major bleeds. Organ dysfunction. Because children with moderate dengue are hospitalized. If they are not doing well, you will do an SGOT PT, will be alarmed to see it in thousands. Liver functions, your renal functions will keep rising, urea is rising, creatinine is going up. These are all the issues that you need to really watch for. So any evidence of organ dysfunction. And recently in 23 guidelines, they included severe metabolic disorders. So when they are sick, severe dengue, you need to have their bicarb, you need to have their blood gases. So anion caps, all these are important. That's the reason we say severe dengue should be referred to a medical college or a tertiary care hospital early, because you need hourly monitoring with CBC plus many more organ dysfunction tests. It can go for anything. It can go for shock, liver failure, encephalitis, encephalopathy. It can go for ARDS, myocarditis, acute kidney injury, coagulopathy, and cytokine storms. So these things are very worrying when a young child, and mostly in the dengue child particular, they will all be well thriving, chubby children. So they are all very normal prior. To lose in 2 days, it's very, very difficult for the treating physician and the family. So no child should go into MODS, which means it should not go to shock, which means you have to catch them at moderate dengue stage, give them proper fluids, 1.5 times their management, as long as possible give it oral, if not, give it IV under monitoring. So any child with any of these features comes under severe dengue, and that is tertiary care management, which we will not discuss in detail. Next slide. Next slide. Severe dengue, yes, it needs inpatient care or an ICU care at tertiary care center. We say A, B, C, D, F, G for my PGs. A is your airway. Keep their airway positioned properly because they may be in alternate sensoria. So breathing should be maintained. If the child is breathing, give some oxygen support. Never use a prongs or a simple mask. Please use a non-rebreathing mask that will only give 100% oxygen for a child with shock. So if you're transferring somebody, ambulance a sick child or a shock, please don't give them simple mask oxygen. That will not help. You give oxygen through a non-rebreathing mask, which is easily available. It's hardly 120 rupees. Please keep these masks in your centers and give oxygen only through non-rebreathing mask, as shock needs 100% oxygen. You don't need to have any hi-fi gadgets. So airway, breathing, circulation. Circulation is what I said is shock. So kai kala thottu paranga, warm aranda, you are happy. Pulses are weak. That child cannot be shifted. Give some fluids, get the pulses back. On fluids, you can shift with somebody who can monitor. So bedside fluid charting and hourly measure of urine output is very, very important for us. And do not rush boluses if you work at tertiary care centers. Let me not go into detail for the tertiary care centers because medical colleges we always have the protocols. There is no shock, please don't bolus them. Hematocrit rise it doesn't mean that it needs boluses, it needs more fluids. You increase the rate of fluids. If you are giving 6 ml per kg, maybe you can just increase it to 7 ml or 8 ml. But that doesn't mean you need to give a bolus of fluid. Bolus of 10 to 20 ml per kg is only when there is shock. Shock means maybe your peripheral pulses are weak, peripheries are cold, your blood pressure is going down. When you have findings of shock, then you start them on boluses. Don't go by your hematocrits and start on boluses. Persistent shock beyond 2 boluses, I think we need to go for colloids. Hematocrit rise achana, it is just the fluid which is leaking. If hematocrit is falling, it is bleeding. So high achana, colloids podlam. Hematocrit fall achana, blood kodukal. That's simple logic. Rendu bolus ku mela papa shock la irundha, you are in trouble. If the hematocrit is high, it's only leak, give fluids. If the hematocrit is down, falling down with shock, give blood. Blood means you give packed cells or whole blood depending upon the volume status of the child. So your lab should be very prepared in tertiary care centers during dengue season. And this point of care ultrasound, I think even in Taluk hospitals, we can just give the ultrasound to find out how the IVC is, whether we give it more fluids or we need to give less fluids, to see the lung, whether there is a lot of pleural fluid or not. So these are signs along with your hematocrit to know whether there is leak. Stabilize all the parameters, your blood glucose, everything. So airway, breathing, circulation, disability is a sensorium. E is your electrolyte, sodium and potassium. F is the fluids you give, how much you give in and out. G is the glucose. So if any sick child has all A, B, C, D, E, F, G maintained, that means the child is safe in the hands of the hospital. If any of these is abnormal, the patient is in trouble, and I think in the present era, the hospital also is in trouble. So all maintain your A, B, C, D, E, F, G in any child who is eligible with dengue. Next slide. So in shock we give 10 ml per kg. If it is very severe, you give 20 ml per kg, rush it over 20 minutes. Then you reassess. If it's improving, go down 6, 3 and 1.5. All these are only hourly fluids. Every hour you need to titrate. If you give and the child is worsening, you keep rising. So beyond 2 boluses, you may need to give colloids or blood. That is decided by the hematocrit. Hematocrit jasti achna you give fluids, colloids. Hematocrit kami achna you probably give them blood. That's it. So beyond 3 boluses, any child with dengue is in trouble. So you need advanced airway support. It may need something like HFNC or BiPAPs or ventilation and all that. That's why if you think the child is going into shock, as early as possible, stabilize and shift it to a tertiary care center. Delayed referral is one of the causes for the death. No matter how much ever we struggle, if the child comes with MODS, we cannot do anything. So please refer them early if you want to refer to tertiary care centers. Next slide. So monitoring, they can go in and out of shock. Like you shock recovery ayachna, then just like that we cannot leave it because it will be in shock, it will recover, it will go into shock, it will recover. This will go on for 48 hours. So inpatient severe dengue cannot go to the hospital or ICU for the next 48 hours, even if there is no shock. It can go in and out of shock. Every hour you keep monitoring children with shock. Crystalloids are always preferred because safe, easily available, cheap, you don't have to refrigerate them, not much of reactions, kidneys are safe. So always prefer to give normal saline or dextrose normal saline only. RL of course, yes. Nothing other than these three. Don't stock Isolite P in any of the pediatric centers for using for sick children. It is not a fluid to be given for a sick child. Colloids, yes, depending upon what you use, hetas or gelatin. But again, you cannot give more colloids, not more than 3 boluses, so not much of a role for colloids. Any refractory shock, assume the child is bleeding, keep your labs prepared for blood. And electrolytes have to be identified. Every 4th hourly we need electrolytes, you need blood gases, you need hematocrits, you need to monitor LFT, RFT, all these. And again, if the child starts having a persistent temperature, cytokine storms or ferritins have to be monitored. Watch for compartment syndrome, abdominal distension, initial of fluid nenapom. Child will be in refractory shock. Unless you know abdominal compartment, they will not come out of shock. They will have severe metabolic acidosis. There are problems in tertiary care centers. Please remember, any child with severe dengue, you have to think about paracetamol poison. Unless you think about it, you cannot diagnose paracetamol because MAC is a specific treatment. Remember that. Next slide. Next slide. Recovery. Yes, everything goes on well. We are happy. Child is happy within 48 hours of leak. Hemoglobin improves. Hematocrit falls. And the fall in the hemoglobin which you get in the recovery place, please don't transfuse them because the malaria fluid கொடுத்ததுனால hemoglobin fall ஆகும். பாப்பா நல்லா இருக்கும், யூரோப் நல்லா இருக்கும், shock இல்ல. Child is doing well, eating. Please don't transfuse them. Transfusion at that point will cause pulmonary edema. So, நீங்க transfuse பண்ணணும்னா child shock ல இருந்தாலும் transfuse பண்ணுங்க. Otherwise, don't transfuse the hemoglobins. And early diuresis. We should feel happy. 0.5 ml to 1 ml per kg per hour is fine. Platelets, don't chase platelets. The வீட்டுக்கு 50,000 தான் இருக்கும். So don't worry about platelets. Itchy rash, problematic for the parents, but it's very happy. If a child complains of itching and rash, I know the child is 100% recovering and going home. So it is very painful for the child, but it's very comfortable for the treating physician. Bradycardia, yes, don't worry, it's a recovery sign. Follow the guidelines for discharge. Standard guidelines are available. If they are there, you can discharge them. Ask them to come back if there is any problem. Next slide. Do's and don'ts to summarize. Suspect dengue in all fevers. Epidemic season, tropical fevers, always think of dengue. Internal fever dengue, likely to be dengue. Yes, treat it as dengue. If it is not dengue, you are happy. Hydrate them and tell them when to return in mild dengue. Handouts on warning signs for mild dengue. Mild dengue, don't hospitalize them. Recognize the leak phase and ask them to come back. Tell them vomiting இருக்குது, வயிறு வலிக்குது, child dull இருக்குது, peripheries cold இருக்குது, urine output கம்மியா இருக்குது, child is breathless. Please ask them to come back. Use only crystalloids. Only T necessary use colloids. So stop DNS, NS and RL, that's more than enough. Blood products, yes, when there is refractory shock. If you admit the child probably you need to do the blood sugar and your CBCs and your sugars. These are mandatory for moderate dengue if you hospitalize without severe dengue. And don't panic. No steroids, no drug other than paracetamol, no antibiotics. Platelets have no role, maybe in a child with DIC, MODS, bleeding, invasive procedures. There is no role for platelets. No hypotonic fluids like isolate P and dextrose cannot be used. No unnecessary laboratory. Do not wait for serology. Do not delay transports. And do not shift an unstable child, however risky it is. Next. So I put in a lot of gadgets. Bedside echo, fluids, sugar, urea, creatinine, electrolytes, OT, PT, BT, APTT, lactate. Don't worry, we don't need anything. We only need a glass which is there to measure the urine output, your vital signs by your hand. You're not a gadget. You need the hematocrits and simple blood glucose by a glucometer. That's all we need. Only those three in red and that is what we do and this is what the mother does. Only these are important to manage dengue even in a tertiary care center. Maybe the labs come in a severe day. Next slide. So these are the gadgets. Please ensure that dengue treating units have these measuring plastic jar. Don't use glass jars, use measuring plastic jars. And remember, paracetamol, right dose, right concentration at right interval, right duration and right indication. Don't tell them you take paracetamol 6 hourly for 2 days. Not at all indicated. Temperature பாருங்க, child dull இருக்கு, கொஞ்சம் painful இருக்கு, sick இருக்கு பாப்பா. Then you give paracetamol. Fever 100 doesn't equate to paracetamol. No, even if it is 100 child is running around, don't run and put the child on paracetamol. Not indicated, not necessary at all. Next slide. Next slide. So discharge, afebrile for 24 hours, within of appetite, stable hematocrits, 3 days post shock. Counts platelet may still be low. You don't have to wait for 1 lakh. If the child is otherwise running around eating afebrile, then you can send them home. And all these are visible effects for you to send that the child is. Next slide. In infants, be very, very careful. Send all infants with dengue to a tertiary care center. That's always safe. Because they will not mount the typical signs like a rising hematocrit or falling hemoglobin and all that. So we need to monitor them more frequently. So dengue in infancy, please refer them because they will rapidly deteriorate into shock. And again, these children are the ones who are prone for paracetamol poisoning also because ரொம்ப சின்ன குழந்தைகளா இருந்தா parents ரொம்ப will be panicked when a child has fever. அதுக்கு paracetamol dose பண்ணிருக்காங்க. Always try to get bottle கொண்டு வர சொல்லுங்க. எவ்வளவு paracetamol எவ்வளவு frequent-ஆ கொடுத்திருக்காங்க, எத்தனை bottle கொடுத்திருக்காங்க, you calculate the dose. 150 mg per kg, it must be alarming for us. Fluids may be very challenging, so please refer all dengue infants. Next slide. So to summarize, just fever, rash, no warning signs. That is mild dengue. Treat them at home. Give them home therapy. Just give them a lot of fluids, hydrate them, give them the warning signs, ask them to come back to you. That's all. If they are presenting with warning signs, vomiting, கை கால் சில்லுன்னு இருக்குது, dull, lethargic, bleeding, breathless, that is warning sign. Please ask them to come and hospitalize. Or any child without warning sign but comorbid, infant இருக்காங்க, underlying heart disease இருக்கு, liver disease or some problem, please hospitalize them. Don't send them home. Monitor them with the vital signs by your hand and your blood pressures through appropriate cuffs, temperatures to see when they are going for afebrile phase, and one lab will be complete blood count, and ask the mother to measure the urine output. So the physician and the lab and the mother, all three are needed for warning sign. Look for severe dengue and shift them early. If they are recovering, transfer them out of hospital within 48 hours. Severe dengue are not touched with the management because most of the colleges have the protocols. So severe dengue, the reason why we lose severe dengue, majority of the time they come to us late. Either they come to us late or there's some problem in reference, in transport. So please don't wait for MODS. Watch for signs of MODS or SGOTPT or elevated urea creatinine. These simple clues, persisting fever, should make them refer early. So I would summarize to say monitoring is very important, for which a physician is important, and simple bedside complete blood count, and the mother should give you the urine output. Chart them second hourly or fourth hourly depending upon the seriousness. Please have a dengue chart when you manage child in the hospital, and refer early dengues. And transport should be documented. Your investigation should be documented. Parents should be counseled, and transport with an attender along with the medical personnel who can manage, recognize at least hypoglycemia or shock, and ensure the fluid patency during transport. Probably if you transfer them early or the parents come to us early, we should not have any mortality in dengue. Keep the caregivers also counseled. Thank you.
Thank you, ma'am, for a wonderful presentation. It's time to clarify our doubts. If anything, I request all of you to ask questions to madam. Thank you, sir. Now I request our Additional Director Disease Control to felicitate our speaker. Now I request Professor Dr. Chandrasekhar, MD, Government Standard Medical College, Chennai, to give the lecture on clinic.
Respected organizers of this meeting, Director of Public Health and Preventive Medicine, respected deans, ladies and gentlemen, good afternoon to everyone. I thank my dean, Professor P. Balaji, for having me here. I thank Dr. Koid ma'am also. She has made my job easy, but I feel it's more challenging also to talk after the lecture. Next slide, please. So we all know that like a dengue is a flavivirus. It's got a distinct 4 serotypes. Then we 1, 2, 3 and 4. The infection with one serotype confers lifelong immunity against that serotype, but subsequent infections does not give any protection. That has to be remembered. It has got a lot of structural and the non-structural proteins. Of course, these things will help us to lab diagnose this dengue virus. Next slide, please. Just to go through this, I think all of us, we know this. The dengue fever, if somebody comes to us with the abrupt onset of fever, the fever is short, abrupt onset of fever with headache, particularly the retroorbital pain, myalgia, polyarthralgia, we call it as a breakbone disease, rashes, The rashes would be a erythematous rash or a scarlet-form rashes. Sometimes they may present to us with minor hemorrhagic manifestations like petechia and purpura also. We call it as dengue hemorrhagic fever if the patient, in addition to the criteria of fulfilling the dengue fever, with some the mucosal bleed, with the thrombocytopenia, next slide, or if the hematocrit is higher than the baseline value to the tune of 20%. Patients with the dengue shock syndrome, they usually continue to have persistent hypotension, cold clammy skin, restlessness. Of course, they will have a weak pulse or absent pulse with a narrow pulse pressure. Next slide. So this was the older classifications dating back to 2009. Next slide. Now it has been changed, little bit crowded, but I make it a little easier. So this is the latest guidelines from the Government of India, which was published during 2023. So whenever we see a patient with dengue viral infections, if they are symptomatic, we need to classify them into 3 groups. A, without warning signs, patients with B with warning signs, and patients who are having severe dengue are categorized into C. Again, these A, B are all divided into the people with risk factor and without risk factor. So what are all the risk factor? Somebody who is elderly, diabetes, hypertension, having some comorbidities like coronary artery disease, CKD, or patients with hemoglobinopathies like G6PD deficiency, or patients who are on immunosuppressants or on steroid. Patients in the category A without warning signs, they can be managed at the domiciliary management can be done, or as a OP patient like they can be managed. But they should have the clear instructions on the development of warning signs, and they should have a follow-up and observation. That is more important. Whereas patients in the category B, they also require close monitoring and possibly hospitalization if they have the comorbids not under control, or if they are found dehydrated and has to be observed. Whereas in the category C, they are subdivided into 3. Those people who are presenting to us with the shock are C1, people with bleeding are categorized to C2, and C3 are the patients who develop some kind of organ involvement. Of course, all these patients in the C has to be hospitalized and managed at the tertiary care level. Next slide, please. I just briefly take you to the importance of this pathogenesis. We all know once the virus inoculated into our body, it started replicating. So mainly in the phagocytes and macrophages, and the viremia starts. Once the viremia starts, the patient begins to have symptoms. That's when the patient develops fever. But we do mount an antibody response. So in fact, most of the dengue infection are self-limiting. They need only paracetamol and assurance and education. If the antibody responses are good, usually it will be able to mitigate the viremia, and the resolution of the viremia and the recovery is the possible thing which we expect. Of course, we all know that this dengue virus is immunity based. As my previous speaker told, the critical phase usually lands upon the 4th or 5th day. But in our clinical practice, we do see patients even on the day 2 or day 3, they will end up with a critical phase. So that is quite challenging. Why it happens? Because of the banning of these cross-reactive heterotypic antibodies, which are responsible for the dengue hemorrhagic fever in secondary dengue. So that's the reason why we get, if the antibody levels are low, we get the critical phase lands up a little bit earlier than expected. Next slide. Of course, it involves the innate immunity. On one side, you have the humoral immunity where you develop the antibodies. I think we all know that the antibody dependence immunity. So these antibodies, they act on the platelets, they act on the tissues, and it can cause thrombocytopenia and bleeding manifestations. On the other hand, like you have the activation of the T cells, which mounts a strong immunological response. It creates a strong immunological milieu that we call it as cytokine storm. So this results in the release of the cytokine mediators, and eventually you get a leak from the endothelium, epithelium. So wherever there is a tissue barrier is there, like it gets wider, and you have vasodilatation. As a result, you get a condition called the capillary leak syndrome. Next slide. We all know that like why a person develops a thrombocytopenia. As I already alluded to, it's because of the destruction of the platelets by the antibodies. But in addition to that, you may have a transient bone marrow suppression in the early stages of the disease. Sometimes you have a peripheral sequestration, particularly in the liver and spleen, that can cause a thrombocytopenia. It not only causes quantitative defect, but it also can cause qualitative defect in the form of cytoadherence platelet dysfunction. But in our clinical practice, we do see a patient can bleed even with a platelet count of 60,000 and 70,000. Many times we may wonder why this patient is bleeding. Is this due to the thrombocytopenia? Maybe. But what we need to look upon is, it's not the thrombocytopenia alone that is responsible for the bleeding. But beyond that, we need to look. This dengue infection can result in an abnormal coagulopathy. So not only it causes a thrombocytopenia, it causes abnormal coagulopathy. Because of the prothrombin complex deficiency, it can result in endothelial injury, and as a result of the endothelial injury at the endothelial glycocalyx, which releases a heparin sulfate, which acts as an anticoagulant and can cause bleeding. It can also cause decrease in the fibrinogen. How do we know that this patient is having an abnormal coagulogram? We need to do a APTT for all these patients. If a patient with a platelet count, usually the spontaneous bleeding is known to happen if the platelet counts are less than 30,000. If the patient is having a 50K or 60K platelets but still found bleeding, please do APTT, where the patient might require a combination of fresh whole blood and FFP. Next slide. So this is the timeline. We all know that like a febrile phase, critical phase, and recovery phase. I don't want to dwell much on that. Next slide. Next. What is important is, I just wanted to reiterate, after the febrile phase, the patient goes into a febrile phase. In that time, the patient or patient's attender may mistake it for a recovery, and they may delay in presenting to us with warning symptoms. That one thing has to be remembered. Similarly, next slide, the viremia can happen, and it comes down over a period of time in 4 to 5 days, and you get the development of antibodies, IgM to start with, followed by IgG. There are certain laboratory features which are hallmark in patients with the dengue. We know that the leukopenia is one thing which is the hallmark of dengue infection. Usually it precedes thrombocytopenia 2 to 3 days earlier, and it recovers earlier than thrombocytopenia. Whereas the platelets, which is depicted in the green line, usually it falls during the critical phase, and it takes a longer time to recover. So even if the platelets are on the lower side, if the patient is otherwise feeling well and hemodynamically stable, we can give you assurance. Similarly, hematocrit is another thing which we need to look upon, which falls down and which corresponds to the capillary leak syndrome, which we classically see in patients with critical phase. Next one. But what is more important is this febrile phase. This is the most important phase which we need to have most of our attention. The patient should be encouraged to take plenty of oral fluids and ensure adequate urine output. That is the most important thing. If the patient lands up with dehydration, the complication can ensue. So the first objective during the febrile phase is the maintenance of the hydration. If the patient goes into the critical phase, they may either develop shock or bleeding or both. So eventually what happens, it can result in organ impairment also. The recovery phase is usually follows the 2 to 3 days of the critical period. Next one, how do we know that like the patient is in recovery phase? The feeling of well-being, that is the most important thing, and a stable hemodynamic status. And they may have a brief diuresis, and they may have bradycardia also during the recovery phase. Of course, there are certain rashes which I will show you in the next slide. Next slide. So these are all some of the rashes which you can see in patients with dengue. Next slide. So these are all some of the impression signs in the dengue. Usually it happens during the recovery phase with mild urticaria. Next one. Why we should worry about this timeline? A patient who is said to be stable, within hours they can develop warning signs. Remember, within hours they can develop, even during the transit also they can develop a warning signs. If the warning signs are not being identified early, they can go for compensated shock. If the compensated shock is not being appropriately treated, within hours again it can go for a hypotensive shock. Remember that during the hypotensive shock, these patients deceptively looks normal or stable with clear conscious level. So that is real challenging. So that's where our clinical examination is the most important tool which we should embark on. Once the patient develops hypotensive shock, within minutes the patient develops a cardiac arrest. If you see the older literatures of WHO, they mention this condition as a walking dead syndrome. The patient walks into your chamber and goes back with dead. Next slide. How do we assess these patients? The history taking, clinical examination, and the laboratory investigation, and this has to be correlated with the phase of the disease and severity. Let us see one by one. Next. The day of the fever is most important thing. So usually the day 4 or day 5 should alert you that this patient is likely to go for a critical phase. So the patient has to be educated about the possible warning signs he or she is going to develop. But more important is the feeling of well-being. That is the one thing which we need to ask, and the ability to take the oral feeds and oral fluids. Again, the urine output, as we see with the pediatric age group, the adult also should have the liberal urine output. Of course, certain common comorbid conditions like diabetes, coronary artery disease, CKD can have a stiff challenge in managing such patients with dengue because they do have more morbidity or delay in recovery. Of course, their access to the hospital is also another thing which has to be ascertained while we are asking the history from the patients. Next one. The clinical examination should be thorough, but we need to make a quick examination. Quick examination on their mental status, hydration, hemodynamic state. Of course, we should look for the bleeding tendencies or bleeding manifestation, rashes, and the respiratory rate. These are all, some of the things are very basic, but we need to do it again and again. Next slide. I'll give you a simple tip on how to assess the hemodynamic assessment. So that is the paramount thing which we should look for. There are certain simple parameters which we do it at the bedside. Even a trained staff nurse can do this. Capillary refilling time, the extremities. We need to look at the extremities. We need to touch the patient's hand and feet, and we should check the pulse. So these things will give some idea about the adequacy of peripheral perfusion. Similarly, the heart rate, pulse pressure, and blood pressure will give the adequacy of the cardiac output, and the conscious level urine output may give information about the organ perfusion. Next slide. This is the most important thing. whenever the patient goes into the critical phase, they go into the state of compensated shock. It is an imperative thing and most important thing to identify a patient who is in the compensated shock. How do we identify? They may have prolonged capillary refilling time, cold peripheries, and their pulses will be weak and thready, indicating the reduced peripheral perfusion. They may have tachycardia for the age, but what has to be remembered is they may have a normal systolic blood pressure with rising diastolic blood pressure. They will have a narrow pulse pressure. That is more important, and they will have, classically they say, நடந்து போகும்போது தலை சுத்துது. So that is a very important clue which you can get it from the patient, postural hypotension. Another thing which we commonly miss is quite tachypnea. Because of the tissue acidosis, they will have increase in the respiratory rate, but they never say that they have மூச்சு வாங்குது. So they don't say that, but if you check their respiratory rate, it will be high. But remember that they will have a clear mentation, and they may have a reduced urinary output. So these are all some of the things which we see during the compensated shock. Next we will see what happens if they go for a hypotensive shock. In addition to all these things, like the patient will have restlessness and they may have a altered sensory, and the patient also would develop a oliguria or anuria, and the respiratory rate will become Kussmaul's breathing. So these are all some of the things in addition to the other features which I already alluded, which can happen in patients with hypotensive shock. I'll show you a next slide. A simple thing, by touching the patient's pulse, we can find out, by taking the patient's hand, like we can find out whether the patient is going for a compensated shock or not. What are all the things which we should look for? We should look at the color, whether it is blanched or mottled, capillary refilling time, temperature, whether it is moist or warm, or the pulse volume, of course the rate. So this goes with the acronym CCTVR. So this takes hardly 30 seconds for us to do these maneuvers, but it's rewarding and life-saving for the patient. Next slide. Coming to the investigation, the first one to go up in patients with the dengue infection is NS1 antigen. It starts as early as the 48th hour, and it keeps rising. And maybe by the 4th to 5th day, you will have start elevation of the IgM antibodies followed by IgG. Next slide. These IgM antibodies will have more sensitivity when the test is done in the later part of the dengue infections. After the 10th day, the sensitivity is almost to the tune of 99%. The rapid diagnostic tests are discouraged. Please remember that, like somebody many times in a community level, they come to us with the rapid diagnostic test, and these tests to be discouraged. Next slide. Dengue IgG antibodies have got limited value, maybe to differentiate primary and secondary dengue. The IgG antibodies have got some role to play. Next slide. This is a very simple test which all of us can do. Within a matter of 10 to 15 minutes, we can get it from the cell counter. So, but it gives lot of information, this hematocrit. Hematocrit in a stable patients, if it is high, indicates the inadequacy of the fluids. The patient has to be given some oral rehydration, or if possible even IV fluids also. In unstable patients, it usually indicates the capillary leak, and the treatment of choice in such patients would be intravenous fluids, particularly the crystalloids. In a patient who is stable hemodynamic parameters, but hematocrit is going down, this may indicate hemodilution also, maybe because of the overzealous administration of the IV fluids. We need to stop the IV fluids. Suppose if it happens during the recovery phase, that is usually it's accepted and we need to wait and watch. But in a hemodynamically unstable patient, if the hematocrit goes down, the internal bleeding has to be looked upon, and we need to find out the cause and source of the bleeding and adequately should be treated. Next slide. I think the admission criteria is already being dealt with. Next slide. The warning signs, we all know that like the warning signs, the recurrent vomiting, if it is more than 3 in number, it is significant. Abdominal pain, the cutaneous bleed, patient is found breathless, lethargy, restlessness. எனக்கு டயர்டாகவே இருக்கு ரொம்ப வீக்காக இருக்க மாதிரி ஃபீல் பண்ணுறேன். ஸோ திஸ் இஸ் அ வெரி சிம்பிள் திங் தட் டெல்ஸ் யூ தட் த பேஷண்ட் இஸ் கோயிங் ஃபார் சம் கிரிட்டிக்கல் ஃபேஸ், மைட் டெவலப் சம் காம்ப்ளிகேஷன்ஸ். Orthostatic giddiness, never ignore that orthostatic giddiness. We have seen many patients who develop orthostatic giddiness, they lapse into the critical phase with multiple complications. The laboratory test, as already alluded, the hematocrit is very much important. The rapid fall in platelet count and low serum albumin, we found that like it's quite significantly, it correlates with the severity of the illness. What the patients with serum albumin less than 2.5, they do land up with more complication. It just indicates the plasma leak, that's all. Of course, all of us, we do the ultrasound, the pleural effusion, ascites, again it indicates the plasma leak. Yeah, gallbladder wall edema again indicates the plasma leak. The one thing which we found it very pertinent as far as the tertiary care is concerned, the adequacy of fluid, which we usually do it with the help of IVC diameter and the collapsibility. So it's a very simple thing which all of us can learn in a matter of minutes and we can practice. So whenever it's possible, near facility with ultrasound, the focus is nowadays available on all the hospitals, all the hospital in medical colleges. You can take this use of this IVC, measuring the IVC and collapsibility. That will give you immense value in finding out the adequacy of the fluid therapy which you are giving. Next slide. How frequently the patient has to be monitored? If the patient present to you on day 1, the CBC has to be repeated on the day 3. If the patient is afebrile but with no warning signs, patient is in the critical phase, we need to check the vitals every 6 hours and make a chart of it, and the CBC has to be repeated every day for the next 2 days. The patients with warning signs in the critical phase, the vital signs and peripheral perfusion has to be checked every second hourly, including the urine output. And the hematocrit has to be checked before and after every fluid bolus, and maybe for every 6 to 12 hours, it depends on the clinical status of the patient. Next slide. The patients, how we can manage the patient as a OP basis. They should be encouraged oral fluids. Water alone is not sufficient and it's not advocated. Please remember, water alone is not sufficient and it's not being advocated. So we need to give juices, cut fruits, barley water, coconut water, soups, or rice kanji, rasam kanji. All these things are very important things which we can advocate to our patients. Of course, patients with the febrile episodes, they have to be managed with paracetamol up to 4 grams. In adult, up to 4 grams is acceptable. Next slide. The patients who are with comorbidities but without warning signs, we need to increase the oral fluids. If they are not tolerated, we can start the patient on IV fluids. That is a maintenance IV fluids, not as bolus. Please remember. And once the patient feels better and stabilizes, we can slowly titrate it down and encourage them to take more oral fluids. Of course, they need to be closely monitored. Next slide. So this is the dosing for the maintenance of IV fluid. Say for example, somebody who is weighing around 60 kg, they will be requiring at least 5 pints of crystalloids, normal saline, for 24 hours. Next slide. Next slide. So this is the management. Of course, is very much available in all the websites and in even our in Tamil Nadu protocols. The patients, dengue patients with warning signs, if they have the systolic blood pressure is being maintained but with reduced peripheral perfusion, with warning signs, with elevated hematocrit. So we need to start the patient on the isotonic crystalloid solution at the dosage of 7 to 10 ml per kilogram for over a period of time, 30 minutes to 1 hour. We need to monitor, once this bolus is given, we need to monitor their blood pressure, pulse pressure, hematocrit, urine output, and capillary refilling time and pulse rate. If the patient improves, we need to titrate the dosage of the crystalloids which we are giving over a period of time and stop it whenever it is feasible and possible at the end of 24 hours, please remember. But if the patient is not improving with rise in hematocrit, then we can try another 1 dose of crystalloids, again with 10 ml per kilogram body weight over a period of 30 minutes to 1 hour. If the patient doesn't improve, we think in terms of the persistent shock, and we can try with colloids or we can try with inotropes. Next slide. Next slide. So this is the algorithm for managing dengue with compensated shock, where the patient is presenting to us with hypotension, where the starting dose of crystalloid is 10 to 20 ml per kilogram body weight as a bolus. It should be given over a period of 30 minutes. And we should look for the same parameters which we have done it previously. And if the patient is not responding, we can try with the second bolus. Next slide. If the patient is presenting to us with a decompensated shock, this bolus, that is, it should be given as a bolus in a quick fashion. It should be given within 15 minutes to 30 minutes, please remember. So similarly, this kind of bolus can be given over a period of time for at least up to 3 times. Please remember, patients with decompensated shock, the bolus can be repeated for 3 times. If the patient fails, then we can try with colloids, or if necessary, we should also look for the cause for the persistent hypotension. Remember that a patient said to have the persistent hypotension, they would have gone in for multi-organ dysfunction. They need the detailed evaluation and maybe inotropes also. If the patient is found to have the low hematocrit and started bleeding, we need to give fresh whole blood with or without FFP. Next slide. The IV fluids of choice are normal saline or ringer lactate. Next one. Next one. So the colloids have got a very limited role, only in patients with hypotensive shock or repeated shock, or in patients despite giving crystalloids to the tune of 20 ml per kilogram body weight, patient is not improving, then we can try with colloid therapy, we can try with albumin, we can try with dextran, or we can try with erythrified starch. Next. So what is the, when we can suspect that patient is having a bleeding? If a person is found bleeding, like they may have a decrease in the hematocrit, as I already alluded to. In addition to that, like whenever a patient presents to us with refractory shock, suspect bleeding, or the patient remain to be in hypotensive shock with low hematocrit, again we have to suspect bleeding. If a patient is found to have worsening of the general condition with metabolic acidosis, again we need to suspect the occult internal bleeding. Next slide. So what is the role of platelet transfusion? Platelet transfusion is now becoming obsolete, and if you give any prophylactic platelet transfusion, it might worsen. You will end up with doing more harm to the patient than doing good. Sometimes it can delay the recovery also. Then what is the platelets transfusion when it is required? Next slide. If the patient is found to be have a bleeding tendency, then we can think about giving a platelet if the counts are less than 10,000. Or if the patient is to be taken up for any surgery or any invasive procedure, then we need to have the they fulfill the criteria. Say for example, somebody is going to be taken up for some cesarean section, at least we should have a platelet of around 50. If the patient has to be taken up for some major surgery like neurosurgery or cardiovascular surgery, you need to maintain the adequacy of platelets at least 1 lakh. If the patient is found to have a clear-cut bleeding and found to have low hematocrit, then we can have the fresh whole blood plasma, whole blood can be given. Or if the patient is having abnormal coagulopathy, as evidenced by increased APDT, we can try even FFP also. Next slide. The criteria for discharge is already been discussed. Afebrile for 48 hours and improvement in clinical status. And they should have recovered from the shock. At least we need to wait for minimum 2 to 3 days before we contemplate on discharging those patients. They should have a stable hematocrit without IV fluids. Please remember. Of course, the platelet will take more time to get recovered. Next slide. Please remember that dengue is a multi-system disease. Sometimes they may present to you with the other organ involvement also. They may present to you with a seizure or a encephalopathy. Commonly, the patients, they do get referral from my colleagues, surgical colleagues, as the patient present to us with acalculous cholecystitis, subsequently found to have low platelet on evaluation, turned out to be dengue. So these are all some of the common instances where the patient lands up in the neighboring department, finally referred to us with dengue. Of course, this is a multi-system involvement where it is known to cause ARDS and pulmonary hemorrhage. This is a pulmonary hemorrhage is quite common cause for fatality, which we have seen in patients who are dying with dengue infection. Next slide. In summary, most of the dengue infections are self-limiting, and day of the illness and the early identifications of the warning signs and symptoms are crucial and it's game changers. The repeated clinical evaluation. In fact, the dengue infection has taught us a lot the importance of the bedside medicine, where is measured in the simple parameters like pulse rate, pulse volume, the temperature of the skin, and so on. Monitoring is the most important thing than giving IV fluids. Of course, we need to educate and counsel all our patients and patients attended. That is the key to this success in the management of dengue. Next slide. So these are all my references. Next slide. So I think the slide is self-explanatory. The prevention is the key, and the thing is like dengue is if it is managed effectively in the febrile phase, preventing them going into the critical phase or identifying the early warning signs would give me a rewarding experience. So with this, I end my talk. Thank you all for the patient listening, and I am happy to take some questions also. Thank you.
Thank you, sir, for enlightening us towards dengue management among adults. And now the floor is open for questions for both the speakers. Mike, please. My left side.
Peripheral area practice, the platelet counts, is there any limit, 1 lakh, below 1 lakh, above 1 lakh? Can you explain?
I think we need to worry about the platelet count. We should be worrying more about the hematocrit than the platelet count. So that is low platelet count is the thing that is due to the natural course of the disease. We have the low platelet count. But somebody is going to develop the complications, the hematocrit value is more important, and the clinical assessment is more important. If the patient is having low platelet count, we need to be more watchful. I agree that this patient requires more watchful, and they require close monitoring and education about the warning signs, and of course, little bit of counseling also. So that is the one which is most important.
As sir said, I just only want to add up. If you have a platelet count which is really very low, clinically child is not bleeding, things like that, you always verify with the manual platelet count. It's always better because when we take it in a counter, sometimes it's a clotted sample, you may get a pseudo thrombocytopenia. So that 1 lakh and below the definition, yes, it is there. And as sir said, we don't chase behind the platelets. Only in severe dengue, when you're contemplating, we go for the platelets. So only to know the trend of rise in platelets, we can do repeat platelets. But many a time when we do it in a counter, we may get low counts. Please verify at least once or twice in a peripheral smear to know it is really thrombocytopenia when you're contemplating for maybe a central line or a PD for an ACS. There it is very important. There you need to know the counts, and that's the only way to know us through a peripheral smear.
Certainly no role for steroid as far as the guidelines are concerned. In fact, the patient is inadvertently given steroid, the probability of bleeding complications are more. The recovery is also delayed.
Thank you, sir, ma'am, for giving the talks. Actually, I am a DHO. My concern is the PHC medical officers. From your talk, I could understand that if the patient is not having warning signs, if the patient is not having comorbidities, they can be managed as OP. I just want to know what all the patients our PHC most can admit and see, and I mean, when to refer, I could understand. But what are the patients for PHC admission? I could not take it from your speech.
See, the concept is, if they don't have any warning sign, they don't need to be monitored. But they should be watched by the caretakers in case of children for the warning signs. So you don't definitely have to admit them. Fever, 1 or 2 pedicure, child is eating well, playing well, urine output is good. That is where you can give them instructions, send them home, ask them to come back in 24 hours and see how the child is improving. Second thing is, if the child has fever, tell them the child can have fever for 3 to 5 days with no other findings. Only fever and rash. No persistent vomiting, no loose stools, no lethargy, no tiredness, voiding urine, it is fine. When the child becomes afebrile, tell the mother, Papa urine pola, tired, get them back to the hospital. If the child is active, playing well, afebrile, started eating, that is done. That's a common typical viral fever scenario. In a primary healthcare facility, home management fluids solunga, when to come for follow-up solunga, afebrile phase anotne or what follow pannunga. Child is afebrile, 48 hours, doing well, apdina, you can keep them at home. That's why we say you ask them to come back once the child becomes afebrile. You see the child to be stable, give them instructions and send them back. The ones with a warning sign, I think in a PHC you have 24 hours facility for a physician to take care, admit them, watch them. If they are improving by 48 hours, without need for IV fluids, voiding urine well, the peripheries are warm, capillary fill is okay, you keep them there in the primary health centers. Which means 24/7 a child or a patient with warning sign should be watched for by the vital signs and at least 8 hourly hematocrits. If these two can be done, they can watch the child in the center for 48 hours. Beyond 48 hours, need for fluids, developing new fever, becoming more breathless, peripheries are cold, you are in trouble, shift them to a tertiary care center. So primary health care, OP and IP management, OP management without warning signs, give them the warning signs in hand, ask them to come back to you in 24 hours, look for warning signs, if there's nothing, send them home. With warning signs, put them in the hospital, give them oral fluids, watch them for 24 to 48 hours. If they are improving, retain them. If they are worsening with warning signs, you think child may go into shock, please refer them to a tertiary care center. And when you send them home, a child is not eating, a child may be afebrile, not eating, looking dull, voiding urine little 0.5 to 0.3 ml per kg per hour. Please don't send those children out of the hospital. 48 hours of afebrile phase, they must stay in the hospital because you don't know when the child will go in and out of shock. If no warning signs, no need to hospitalize. If warning signs, hospitalize. If not improving the warning signs, refer them to the hospital. That's in summary.
Sir, sir, you said there is no role of antibiotic in dengue, but nowadays we see a lot of mixed infections. So at the primary healthcare level, usually the patient reaches on the third day or the second day of fever. So is it advisable to start the patient empirically on doxycycline because it can also cover scrub typhus and leptospirosis?
A patient with acute undifferentiated fever, we can start the patient on doxycycline, we have guidelines for that. But dengue is different and we can easily diagnose or suspect at least as the person has a probable dengue infection. In such patients, there is no role for antibiotics. If the patient complicates, many times like referral setup, like they would have started on antibiotics, there is no need to continue those antibiotics. Though doxycycline has got multiple roles. It can be effective in malaria, it can be effective in scrub typhus, it can be effective in leptospirosis, and it does have some antiviral actions also. And it was even being tried in patients with dengue infection, and it also reduces the inflammatory markers, particularly the metalloproteinases. Though there are such small studies have shown some little beneficial role of doxycycline, it has not been proved in large RCTs. Hence, it is not recommended by WHO as well as by our guidelines. There is no role for doxycycline. Is there any role for antibiotics in patients with dengue during the course of infections? If the patient remains to have hypotensive, we should look for other alternatives. Or if the patient's temperature does not settle down, usually the temperature dips down by 4th or 5th day, the patient continue to have a febrile episode even up to 7th day, 8th day, then we can suspect a possible mixed infections. So what are all the infections that can coexist? Commonly, the infections, dengue can coexist with malaria, dengue can coexist with leptospirosis or gram-negative organisms. So we need to do a battery of tests and we can find out, then accordingly, and we can decide individualized. The treatment is individualized to start the patient on antibiotic. Only in such cases, maybe it's permitted to have antibiotic, otherwise it's not necessary. There is no role for doxycycline.
Thank you, sir. Thank you all for your patient listening. Now I request our additional director, Disease Control, to felicitate our speaker. Thank you all for your patient listening and presence today. So this will commit us towards dengue-free Tamil Nadu. in the near future. Definitely, we all work together to make it a successful one. And now I request all of you to join for lunch. I request all the other department officials also please join us for lunch. And also DHOs please stay back for another just 5 minutes. Others can move to lunch. Thank you.